When you talk about backache or degenerative disc disorders of the lumbar spine, a little bit about clinical background. It is one of the most common clinical complaint that a patient goes to GP with. And all of us have backache sometimes in life, and 85% would have backache which will make you moribund or bedridden for a few days throughout your life. The etiology of pain because of disc degeneration or fascial arthropathy is very complex, and it is usually combination of mechanical deformation of the disc or the facet and presence of inflammatory mediators which are associated with degeneration. Beyond this disease, there are several other pathologies which are responsible for backache, and when we look at MR, we should be aware of that and should be looking for it. For all these, MR obviously is the gold standard for imaging, but understanding anatomy is of immense importance, and that's what we'll do in next half an hour. It definitely allows us to have better understanding of degenerative disc diseases and disorders associated with it. And for our spine surgeon, it makes minimally invasive interventions and microsurgeries or microlumbar discectomies or scopy allowed surgeries possible. So what we'll do in next half an hour, 45 minutes is look at normal anatomy of the lumbar spine, a little bit about cervical spine, degenerative disc disorders, disorders which cause backache from posterior elements, spinal canal stenosis, the primary one, as well as secondary one, and a few unusual entities which can simulate degenerative disc disorders, but we need to understand and identify them differently. The basic consensus on what should be done when we are doing MR imaging in terms of sequences is sagittal T1, sagittal T2, axial T1 and T2, coronal stir because you don't want to miss out anything else like inflammation or infection, sagittal and coronal myelogram. Most of us have now given it up. In cervical spine, axial T2 is replaced by basically a 3D very thin imaging sequence. We call it cube on G. So it gives you about 0.8 millimeter isotropic images which you can reconstruct in different planes. A dynamic study when you're looking at instability either at atlantoaxial junction or in the post lumbar discectomy situation or even cervical region, and gadolinium primarily used in non-degenerative disorders, but we can also use it when there is specific issue like fascial arthrosis or post-operative spine. So these are the current guidelines provided by ACR and ASNR. In terms of slice thickness, there is insistence of 3 mm in the cervical spine with less than 1 millimeter gap. We keep a gap of 0.3 millimeters. And thoracic and lumbar spine, you have 4 millimeters of thinner sections with a gap of 1 millimeter or lesser.